Hey guys, so to go through the neurological system, we know that pregnant women, especially early on in their pregnancy, have a lot of headaches from all of the increased progesterone that their ovaries are making and then that the placenta starts to make. And that progesterone vasodilates things, which is going to go ahead and cause the headache symptoms. And just to put into context, that vasodilation that progesterone does is also what's causing constipation that occurs during pregnancy because the GI tract is dilating, so things are not going through it so quickly. So women are tending to be constipated during pregnancy. So the other thing neurologically is talking about carpal tunnel of pregnancy. This will resolve, but if you think of the radial and ulnar nerves in your arm, they're getting compressed from extra fluid, all that extra volume that's on board when you're pregnant, and that will resolve after pregnancy is over. But we have women wear just braces that you can get at CVS or over the counter at night, and that helps with the carpal tunnel. So musculoskeletal, so the symphysis pubis, right, the center of the pelvis is going to widen a bit. And why is this important? Well, let's think about that phrase lightning, right? When the baby's head is engaging in the pelvis, we want the pelvis to be as wide as it possibly can be. So that's a positive thing. We know women can be a little unsteady given their rebalancing, having a full-term pregnancy, so unsteady gait. Lordosis we talked about, and I have in the next slide the image of what lordosis is going to look like in the back. Round ligament we talked about during the first class when we discussed anatomy. That round ligament, you can look at where it innervates here when somebody is gravid or full-term pregnant, right? You can see that this is going to cause a lot of sharp shooting pains right on her side where that running up around that ligament. This is showing you the change in the curvature of a pregnant woman, right? So it's going from 1, the non-pregnant state, to 2 and 3, the curvature change, that lordosis of pregnancy. So the hormones that the placenta is secreting are these 4 that are listed here, and I want to add one more for you. That final one that I want to add is called HPL, okay? So we're going to add HPL, but let's start from the top. HCG, right, we talked about last class, that is secreted by the placenta, and that is saying that somebody is pregnant. That is the pregnancy hormone, human chorionic gonadotropin. Estrogen and progesterone, so early on, right, these 2 are secreted by the ovaries, and then once the placenta develops, it's producing them as well. Progesterone, right, being our lifeline hormone, lifeline to the pregnancy. Relaxin is a hormone that's produced by the placenta. Relaxin is produced to help relax joints, right? So like that widening of the symphysis pubis, helping to relax joints to compensate for all that pressure from the uterus and to help with delivery. Okay, so HPL, why did I add it? HPL is secreted by the placenta, and it is the anti-insulin hormone that we discussed. Okay, anti-insulin. And you want to just put a little sidebar here so you remember that when we talk about gestational diabetes, it is an overdrive. When somebody has gestational diabetes, they're producing too much HPL. Their placenta is secreting too much HPL, so stay tuned for that. We also discussed, right, weight gain. This is for a average sized woman. A woman of a normal healthy BMI should only gain 25 to 35 pounds in her pregnancy. Again, you are eating healthy for yourself and your baby. That conception of eating for 2 should be thrown out the window. You are eating healthy when you're pregnant. So pregnant women often ask, where does all the weight that I'm gaining go? I think this is a great visual. We discussed today, right, plasma blood volume, super important fact, increases by from 5 liters all the way on up to 7, so 40 to 60% increase in plasma blood volume. That accounts for 3 to 4 pounds that she gains, guys. That's a lot, right? So the other thing that's happening, the placenta weighs stuff. The baby has weight to it, clearly. Her increased in breast tissue size that we talked about for physiological changes in the breast accounts for weight. So you want to reassure somebody when they're looking at the scale, especially if you're working with a client that's had an eating disorder. This visual helps to understand that it is not that she is gaining fat, it's a distribution of where all the weight is going. So we'd be remiss if we didn't talk about, right? We focused today and talking about the normal weight woman. I'm sorry, guys. We focused today speaking about the woman of a normal BMI, right? And gaining 25 to 35 pounds. However, we need to consider when somebody is underweight that they have more weight that they should be gaining. And conversely, if we have somebody, which many of our patients fall in this category, when they are in the overweight BMI category, look at their weight gain, guys. It's only 15 to 25 pounds. We really, really are cautious about how much weight women gain, especially when they're starting overweight, because of all of those pregnancy complications we discussed that can be precipitated by too much weight gain. So the three big ones, right? Gestational diabetes, preeclampsia, and a difficult labor and delivery, all due to too much weight gained during a pregnancy. Okay, these next couple of slides are NCLEX laden questions. So you can imagine they will probably show up on exams as well if they're NCLEX laden. But there are three things that can be thought of as nitpicky, but we're going to discuss why it's important to know the difference. And clearly, if NCLEX thinks it's important, we need to know this. So when somebody comes in to confirm their pregnancy, the ways that we confirm pregnancy fit into three different categories. So there are things that say it is presumptive that she's pregnant versus it's probable that she's pregnant versus she actually truly is positive. So the third category, guys, is when we actually know that she is pregnant. Somebody that has presumptive or probable indicators of pregnancy may not, in fact, actually be pregnant, okay? It is not unless she has one of what we describe as positive indicators that she is actually pregnant. So, the first category, when it is presumptive that somebody is pregnant, these things can occur, okay? So, amenorrhea, right, means no period. Okay, so no menses or period. So just because she missed a period doesn't necessarily mean she's pregnant. She could have abnormal menstrual cycles, etc. And clearly, just because somebody's nauseous and vomiting, fatigued, has increased urine frequency, or breast or skin changes, or vaginal and cervical changes, those are just presumptive indicators, okay? Now, you're going to look at this fetal movement and say, how in the world can you be telling me that she's not pregnant if she feels fetal movement? Well, I have to tell you that there are psych patients who will say they feel fetal movement in their belly and they are not pregnant. I have had that happen where somebody says that and we go up to evaluate them. It is not just psych disorders, but let's think about it as just because somebody says they feel a baby moving in their belly, it's still considered a presumptive indicator, okay? All right, we're moving into that second category, guys. These are the probable indicators of pregnancy. So you can sort of go through and see, right, this abdominal enlargement, cervical softening, which was our Goodell's sign from the start of this material, so our Goodell's sign. Ballottement. So this means that as a provider, we touch a woman's cervix and feel sort of a bounce, meaning the baby's head or a portion of the baby, right, it sort of bounces and rebounds. That the woman reports that she feels these Braxton Hicks contractions, that as the provider you sort of palpate and feel the outline of a fetus in her belly, and that she's had positive pregnancy tests, urine or blood. Now, you're now going to be saying, well, pregnancy test, how can that just be probable? Well, we will talk about pregnancy complications, but one of them I started to talk about was molar pregnancy, and I said we'll talk about it when we talk about complications. A molar pregnancy is when only the placenta is developing, not an actual fetus, but her pregnancy tests would all be positive. So again, these all fall into that second category of probable indicators. Okay, this is showing you ballottement that I just described. So the green on the bottom here is the provider's fingers, and what it is it's just a gentle tap on the cervix, and it's not harming the baby in any way, but it would push the baby up, and the provider in the second stage here, then the third one, the provider would feel that head back in its hands. Okay, the last category, the third, this is the only way to tell for sure she is positively pregnant, the positive indicators. So there's only three of them, so it makes it sort of easy to remember these three are positive indicators. So you've auscultated fetal heart sounds. You actually feel fetal move. So you auscultate fetal heart sounds. How do you do that? Usually with a Doppler, so it's an ultrasound technology, and you hear the fetal heart. The examiner, so the midwife, the obstetrician, actually feels the baby moving, right? So is doing their exam, actually feels fetal movement, not the patient, but the provider. And then the third one in this category is actually doing an ultrasound and visualizing the fetus. Okay, so I think the way to know these and learn them is to start with positive, get those down, and then work backwards in terms of learning them. But if you get the positive ones down, then deciphering between presumptive and probable becomes a little bit easier. All right, so fetal movement is the term for fetal movement in the obstetric lingo is called quickening. I think it's sort of a nice way to describe it. You feel this quickening inside of you, and that's your baby moving. So a prima gravida, the first term I have here, is somebody who is having her first baby. Preemie, right? Prima gravida, for first baby. She won't feel fetal movement until she's about 20 weeks pregnant. Okay, so about halfway through her pregnancy. Then you go to a multigravida. That's somebody who's had at least one or more babies, and she is going to feel her baby move a little bit sooner. Well, why is that? It's just because she's more attuned to it, because she's felt it before. Now, you have a spouse, a partner or a spouse who says, when am I going to be able to put my hands on my partner's belly and feel that baby move? It's usually not until the woman is closer to 26 to 28 weeks that the partner will actually feel the baby moving, okay? So it is later than mom can internally feel it. It's going to take at least another month and a half, 2 months before a partner can feel, or any family member or friend can feel from outside. All right, so prenatal care can also be referred to as antenatal care, similar, same phrasing. So what does it actually involve? So we've discussed the importance of preconception care, right? Preconception care, talking about folic acid, talking about any risk factors that woman has. Then, once she's actually pregnant, she comes in for what we call a first prenatal visit. So what becomes important here is her history, right? So in her history, you want to know her past medical history, her past surgical history, and her past gynecological history. Clearly, the second bullet point, that her past pregnancy history, is incredibly important. So this here is when you're going to ask about her G's and P's, right? And you're going to find out what happened in those past pregnancies. Were there any miscarriages? Were there preterm births? So, but getting her G's and P's and all those details, that's going to help you here. You want to know her vitals, right? Is she hypertensive at the start of pregnancy? We'd want to know that. We'd want to know if she's obese. Clearly, we can see that, but we want to know what the BMI is and calculate it. And then we want to do a physical exam. So often women come in for this first prenatal visit anywhere from, 6 weeks all the way on up till 12, really. So that's the first prenatal visit, okay? Then they start coming in monthly, and they do that every month until they hit about 28 weeks of their pregnancy. What do we do when they come in for these subsequent visits? Every pregnant woman at every visit is going to have her blood pressure taken, and then she's going to also have a urine sample. In that urine sample, we're testing for sugar and protein. Okay, every visit she's going to leave a urine sample. So blood pressure, urine sample, and then we're going to listen to that fetal heart. We're going to talk to her. We're going to answer any questions she has, but auscultation of the fetal heart. Okay, so then trimesters of pregnancy. So how do we sort of break this down, right? The first trimester, beginning portion of pregnancy, is going to be right from when she gets pregnant up until the completion of her 12th week, right? And then we're going to go here to her second trimester, and it's going to be 13 weeks all the way through 28 weeks. And then the third trimester is going to be 28 weeks and 1 day, all the way through 40 plus weeks. Why do I say 40 plus? Because again, most